We have colleagues from India and they're talking for Plasticos, and they asked me to talk about 5 important points that I think impose bariatric. First point is the patient wish, and you have to understand exactly what the patient wish. And the most important thing is tell the patient and be sure that the patient understood what you could really do for him. So if the patient wish comes direct with what you can do in the result, you have a nice case. Second thing is the technique that you're gonna use. There are different patients and different techniques. Why? Some patients have a massive destruction, so they need a reconstructive surgery to dress, to move, to have hygienic purpose. Other patients have not such a massive destruction, so the result will be more aesthetic. So not only for dressing, but also for undressing. Knowing the difference is very important for choosing the technique. If you choose the wrong technique, you can be the best surgeon and the result will not be good. So choose the technique because the patient needs, so it's very important. Other thing is the pre-ops. These patients have malabsorption syndrome provoked by the bariatric surgery. So you must be aware that the red blood cells are very important. So never take a patient to the operating theater under 12 hemoglobin, under 37 hematocrit, and under 3.9 millions or 4 millions at counting blood. And also the proteins. The proteins at normal level will be excellent to avoid the ACEs. Other thing, the association. The association is good because it's a win-win situation. So the patient do 2 or 3 procedures, instead going 3 times to the operating theater, go only 1 time. Instead be 3 times out of the job, will be only 1 time. 3 times of recovering post-op, only 1 time. So it's good for everybody, for the employer, for the hospital, for the surgeon. But you must be sure that all the pre-ops are okay. And the post-op. More important thing, in my opinion, is early ambulation. What can kill your patient is thromboembolism. I normally do only mechanic measure, but early ambulation is very important. So now in my patient, I make the patient ambulate in the post-op, like 3 or 4 hours post-op, I make the patient stand up and ambulate. In the day after surgery, they go home, walking, with the compressive antithrombotic socks. They ambulate, and the more they ambulate, the better they stay. About the appropriate garments, also, you need a soft compression garments for the brachial, for the thighs, for the abdomen, for the breast. And these garments will be necessary to be used at least 3 months to avoid to have space for seroma. And seroma, you will have seroma. Everybody has seroma. I have seroma. You're gonna have seroma. And the seroma is punction, aspiration, and compression. Punction, aspiration, and compression. Normally, seroma goes out no longer than 30 days or 45 days. So if you follow your patient and see seroma, punction, aspiration, and compression. Sometimes you have 500 milliliters, sometimes you have only 100 milliliters, but it goes okay, no problem. And early results. Tell your patient, the results start to get better and better after 1 month. So prepare your patient to start to see the results after 1 month. I think this is, in my humble opinion, the combination of my experience in the last 20 years in post-bariatric. Thank you. Bye-bye.